In the U.S., a rare disease is defined as one impacting fewer than 200,000 people, often not large enough to attract commercial treatments. In fact, today, 95% of rare diseases still have no FDA-approved treatments. Sadly, 30% of children with rare disease will not see their 5th birthday. Who is fighting for them?
When we work in rare diseases, it is an urgent mission. Our timeline then is not just a piece of paper and a goal. It's someone's life. You treat a patient with rare disease and you see this family who's been all their life thinking about the decline of their child. I like to think of them as a family treading water. We're people arriving the shore. I want us to blaze a trail and take on diseases others have been afraid to take on.
Working together, we can provide hope for these often neglected patients.
Thank you so much again to our sponsor, Osteogenesis, for this session and their support. And now I want to introduce a OIF Board of Directors member, Jim Early. Thank you, Jim.
Thank you, Michael. My name is Jim Early. I am a member of the Board of Directors for the OI Foundation. My relationship to the foundation and to OI comes through my grandson, Matthew, who has OI type 3. I'd like to reinforce what Michael said. You'll be seeing a number of videos today, like the one for Ultragenics, and it's important that we thank them because without them, we would not be able to put on a conference like this. It's my pleasure now to introduce this morning's speaker, Dr. Michael Bober. Dr. Michael B. Bober is the director of the Skeletal Dysplasia Program at the Alfred I. DuPont Hospital for Children in Wilmington, Delaware, and a professor of pediatrics at Thomas Jefferson University Stanley Kimmel Medical College. Dr. Bober completed his combined MD PhD program in biomedical engineering at Tulane University. His dissertation research focused on the genetic response of bone to mechanical stimulation. He then went on to complete a pediatrics residency at Tulane University and a medical genetics residency and fellowship at Johns Hopkins University. He is board certified in pediatrics, clinical genetics, and molecular genetics. His clinical practice is focused on the diagnosis and management of children with skeletal dysplasia. Welcome, and thank you, Dr. Bober.
Good morning. Thank you, Mr. Early, Tracy, the OI Foundation, Michael, everyone for the invitation to be here and to speak. I'm going to look for a couple nodding heads to confirm that you guys can see my screen. Perfect. And let's moving on. So, I was tasked with this talk of navigating a new diagnosis. And as someone that's been involved with OI and, as you heard Ultragenics say, rare disease for essentially my whole career, navigating a new diagnosis is something that families do for 20 or 30 years at a time. There's always something new. There's always something changing. But the point of my talk and what I want to try and get across today for you are really the fundamental basics. I want to try and teach you a little bit about the history of OI. How did we get to this place today? And I think if we can understand some of the processes and in doing so, understand some terminology, it will enable you, the family, to go meet with your medical professionals and be able to communicate in appropriate terminology and appropriate words, and therefore end up receiving and soliciting better care. So to do that, I want to talk about history of OI, the molecular basis of OI, a little bit of the basics of inheritance patterns. What are the sort of more newly recognized forms of OI? And then bring it back around to a very clinical and pragmatic perspective. And there is going to be a fair amount of time for questions and answers at the end. So please chat them, and Michael will lead that session. So if you want to go back to the beginning, you have to go back into the late 1700s, where there was a Swedish surgeon who described in the medical journals a family of 4 generations that had bone fragility and fractures. And he called this condition osteomalacia congenita. About 50 years later, there was a French pathologist named Lobstein who wrote this treatise. I will leave to our French interpreter to say correctly. And in this treatise, he described 3 children from one family affected by fragile bones, and he created his name for this condition. But the term itself, osteogenesis imperfecta, as you can see here, was actually termed in 1849 by a Dutch pathologist, Willem Vrolijk, who, this is a hand-drawn picture that he drew in this book that he wrote about different kinds of conditions and birth defects. And here you can see what we now would know as Wormian bones and very large fontanelles and rib fractures. So this is where osteogenesis first came into use back in 1849. But 1849 was not the first time that we've seen osteogenesis imperfecta. In fact, this mummy was unearthed by John Garstang, who was an archaeologist at the University of Liverpool in England. And this mummy is in the museum in London today, but it's from about 850 BC, the 22nd dynasty. We know for a fact there were children born with OI more than 3,000 years ago. So we flash forward to 1906. Dr. Lusser, a Swiss pathologist, recognized that the previous descriptions were all the same condition. And here we have, from the very beginning, more than 100 years ago, the idea that OI was broad, it was heterogeneous, and therefore it warranted classification. It warranted us as physicians to be able to recognize that there were different sort of flavors of the same condition. So there was termed a congenita or Vrolijk type, and these were children that were identified with fractures as soon as they were born. Then there was the so-called tarda Latin for late, so a later onset, or Ekman-Lobstein type, when the fractures occurred after the first year of age. In 1949, again from Scandinavia, there was a Danish researcher who performed his PhD dissertation, which was called OI, a study of clinical features and heredity in 55 Danish families and 180 different individuals. And now, here comes the slice and dice, because he said, well, tarda type, there's actually babies that are born that don't have fractures at birth, but have fractures in the first year. And that fell through the cracks of the first classification. So he added this gravis type. So we had a congenita, we had a tarda gravis, and now we have a tarda levis based upon, very simply, the age of the first fracture. And then we have to take a big jump forward. And the big jump forward comes all the way to 1979 to Dr. David Salentz. Dr. Salentz is part of the OI community still. He lives in Australia now. Back in the 70s, before he came to the United States to train in Los Angeles with Dr. David Vermoyne, and then he went back to the University of Melbourne, and he started to write about genetic heterogeneity and osteogenesis imperfecta. And this is the summary, this is the abstract of the paper that he wrote in 1979. And he basically said, look, in my clinic in Victoria, there are 4 distinct syndromes. There's 4 ways that people present with OI to my clinic. The largest group of patients showed autosomal dominant inheritance with fractures and blue sclera. A large proportion of adults had early onset hearing loss, predominantly conductive. There was a second group who were the majority of infants born that all died before or soon after birth. There was a third group whom had fractures at birth, that these fractures were progressive. They led to deformity. The blue sclera wasn't as much. And here you can read very clearly the mode of inheritance was not resolved by this study, but it's likely heterogeneous with both dominant and recessive forms. And essentially the fourth group was one that was between the first and the third. Now, for those of you who are new to OI, you might ask the question, why were they numbered in such a weird order? And the answer to that question has a lot to do with this man, Dr. Victor McCusick. And Dr. McCusick was a geneticist at Hopkins. And Dr. McCusick loved to categorize and number things. And he had his hands throughout genetics all through the 60s, 70s, 80s. And you can still find this series of books, Mendelian Inheritance in Man, now online and updated. But these are the first 11 editions that were in print. And if you asked Dr. Salentz, he will tell you that Dr. McCusick told him that he would not publish this paper, he was the editor, unless he numbered these groups. You have to give them numbers, he said. And David said, all right, fine, I'll number them. And what it turned out to be is the number is reflective upon how often they were seen in Dr. Salentz's practice. So 1 is the mildest and 2 is the most severe, and 3 and 4 are in the middle, as opposed to having it be a graduation of classification. So type 1, as we sort of know it now, it's mild OI. Patients typically have no skeletal deformities and normal, typical, or near typical stature. OI2 is extremely severe. It's typically, there is early onset of death. Type 3 is surviving children with deformity. And again, type 4 is somewhere in the middle. And it's important to recognize that there are people that live in between these categories. The categories are not black and white. And sometimes it can be a little difficult and take time to distinguish. For example, if you have a skeleton and you don't have any deformity in it, but then at 8 years old, you fall and you break your leg and your leg heals with deformity. Did you really change from a type 1 to a type 4 because now there's deformity? Is it possible to have 2 types? And I think the answer is not really. Each person has their own individual form. that we try to use classifications to help us understand where in the spectrum people are. And the spectrum itself is not black and white. Okay, so with that historical piece being said, I want to switch gears a little bit and talk about some basic genetics. So I think we all know that our bodies are made of cells, and there are many different cell types. One of the important cell types, of course, that we're interested in is bone cells. And in each cell, there is a nucleus, and in each nucleus, there is a chromosome, 22 pairs of chromosome, 22 autosomes and 1 sex pair of chromosomes to give a total of 46. And these chromosomes, excuse me, consist of about 3.3 billion base pairs of DNA in each individual that are organized into about 22,000 genes. And for the most part, we have 2 copies of each of these genes that we receive from our parents. Now, if you look at the structure of a gene, here you can see the double helix. The structure of the genes are divided into 2 primary parts. There's an intron and an exon. And exon is expressed to become the protein, whereas the intron is removed. And here you can see the process of transcription. So a DNA is copied and made into an RNA. That RNA is processed, and you can see how the introns get removed, and what's left is just the red and the yellow. And using this code where 3 nucleotides are converted into an amino acid. So the RNA is always 3 times as long as the protein. And this is the basic genetic structure that we have. And I'm going to say, and we'll come back to this in the future, that when we talk about this, we need to come up with a uniform way of talking about an address or a location, a position inside the gene. And the way this is done is when we talk about a genetic, a DNA position, we use the convention of a C dot. We always start at the beginning of exon 1 and number sequentially until you get to the end of the exon. When the C dot number stays the same, but then we use plus signs. So this, the first nucleotide after this exon in the intron would be 36 plus 1. Until we get really close to exon 2, and then we use the minus convention. And this is the way where this is the convention that we use. So keep this in your mind. I will come back to that in a bit. So how does this matter for us? Well, here you can see back in 1983 was the first mutation that was described in Osteogenesis imperfecta. This was Dr. Prokop's group in New Jersey, and he recognized that inside of a collagen gene, there was a deletion, there was a section missing, and that was associated with a child, a type 2 child who had OI. And subsequently, we've learned that collagen 1 protein is made up of collagen 1 alpha 1 gene and 2 copies of this and 1 copy of this, and they braid up. The alpha 1 gene is on chromosome 17. The alpha 2 gene is on chromosome 7. These genes are quite large, 51 and 52 exons respectively. Here you can see this collagen 1 alpha 1 chain has 18,000 base pairs, 36,000 base pairs for alpha 2, and that's primarily because there are more intron base pairs. And when you finally edit these genes to the protein level, you can see they have approximately 1,400 different amino acids. When we go to look at the protein, you can see here, this is a braid. So we have 2 alpha 1 chains and 1 alpha 2 chain that braid up to make the protein structure. In order for these molecules to braid, they have to sort of twist on themselves. And the way they do that molecularly is they all twist around a glycine amino acid. Glycine is the smallest amino acid, and that's why the twist occurs in this position. And in the collagen 1, alpha 1, and alpha 2 proteins, it's usually glycine is every third. So if you look at the black dots, they represent glycine. The first position is usually a proline. The second position is usually a hydroxyproline. These tend to be not as important as the glycine, but this is the general way. These proteins braid themselves up. The front edge is cleaved off. The back edge is cleaved off. And this big coil in the middle goes and lives in the bone. And we clearly know now that mutations in both of these genes can cause OI. We know that mutations in these genes are really transmitted and inherited in an autosomal dominant way. We know that using the Solence criteria, all of the types of OI, mutations in these genes were identified. And what this meant in the 80s as this was happening was the idea that each type of OI was going to be caused by a distinct gene sort of fell away and was replaced with the idea that where along that triple helix the mutation occurred was going to, in fact, tell us what kind of OI somebody had. Mind you, this is a hypothesis from now 40 years ago. And here you can see a review article from 1991 in Peter Byers' group, who talked about what types of mutations could be seen in these 4 types of OI. And I want to just talk a little bit about inheritance patterns. In genetics, we love to draw pedigrees. Males are square. I think that's an easy mnemonic. Females are circles. When we're not sure of the sex, it's a diamond. When people are affected, we color them in, and we usually put an arrow to define the person that we're talking about. When somebody dies, they get a slash. This is the way we designate twins, but what's important is this is what we call the relationship line or the union line. So here you can see this would be, for example, a husband and wife. This is a husband and wife who have some sort of genetic relationship. They're cousins, for example. So this is an example of a dominant pedigree. You can see the father has, let's say, OI. The wife does not. And they have 4 children. two have OI, a boy and a girl, and a boy and a girl do not. So this is a pattern of inheritance where there's a 50-50 risk. Unaffected family members don't carry it. You have it or you don't. And the number of males and females is the same. A recessive pedigree looks more like this. Everybody in the family really looks unaffected except these two siblings. And in which case what was happening here was this mother and this father were both carriers of a gene that didn't work, but did not manifest with any signs or symptoms. And with each pregnancy, there's a 1 in 4 chance that they pass the faulty gene along. And again, males and females are equally affected with this kind of inheritance pattern. This is another way of looking at the same thing. Here you can see cousins, and hence the double union line. And when you see a pedigree like this is highly suggestive of autosomal recessive inheritance. And there's another type of inheritance pattern that's going to be important for all of us, and that's called gonadal mosaicism. And what that means is here you can see a father had 2 different partners and had 2 children, a boy and a girl, who were both affected. But nobody has it. Could this be recessive? Well, it could be. Be especially more common if these 2 women were sisters or related, but the more likely scenario is that inside the testes, the mutation exists in this father, and as he goes to create sperm from those testes, he passes the mutation along. And this is called gonadal mosaicism. All right, so now we're switching gears again. Just an important reminder to drink your milk. And I saw Dr. Gloria was on here, so good morning, Dr. Gloria. This next series of slides really is all of his work, really excellent and great work. And 2000, so now we're 22 years ago, we're moving forward. Dr. Gloria described a type of OI, which he termed type 5, a new form of brittle bone disease. And in this paper, he talked about 7 patients from 7 different families with what looked like an autosomal dominant inheritance pattern. It was type 4-like, so it was moderate. These people had some deformity. A significant number had hyperplastic callus, which means somebody breaks a bone. Here's the fracture. And then instead of just a simple callus to heal this, the callus explodes and becomes hyperplastic. And you can go all the way back in the literature to close to the turn of the last century and find reports of people thinking this was a tumor and this was bone cancer. So this is another form of OI, more recently described, but been around for a long time. You can see there's several metaphyseal bands. There's some, for people like me, this is a really strong clue in an infant that this child has type 5 OI. I think everybody would agree that we can pick out these children clinically based on their x-rays and features like this interosseous membrane calcification, and certainly if they have the callus. So there is something unique about these children in a way that you can recognize them in the clinic from clinical features. Here's 2002, Dr. Gloria again described what was now termed type 6. 8 patients from 7 families. These seem like they were recessive in their inheritance pattern. They did not see teeth, eye issues. A lot of them, half of them had ligamentous laxity, but here you can see significant involvement of the spine and some significant deformities in the extremities. We keep going. Again, Dr. Glorio, 2002, type 7, 8 patients from 1 family. Again, sort of a moderate phenotype. They didn't have DI, they didn't have ligamentous laxity. These folks, the type 6 and the type 7, were almost impossible to distinguish clinically from other people with type 4. This one was distinguished because it was clear that there was an autosomal recessive form. This one was distinguished really because of Dr. Glorio's use of bone biopsies. And he was able to tell that these children had a different pattern when their bone was looked at microscopically, but it wasn't distinguishable based on simple physical exam or x-ray exam. This is the pedigree from Dr. Glorio's paper. You can see the double line. So this is the First Nations community in Quebec. So many affected members in the family. Here we see carriers with children. So this was pretty clear going to be a recessive form. And this is where I'd like to point out, but Dr. Salentz in 1979 said, we know there are recessive forms of OI, and he included that in his classification. So what happened next was I would say sort of a virtual controversy, an area of contention, an area of disagreement within the OI community, and it's spilled over. I think it's a little bit more resolved today, 20 years later. But I do think that this is the source, I'll show you here coming up, of confusion that a lot of families have when trying to understand what type of OI their child has. Because now we've gone 4 or 5 years later, 2006, and all of a sudden, these phenotypes, these type 5 and type 6 and type 7, all of these are now being able to be identified molecularly. And they're not collagen 1 and they're not alpha 1 or alpha 2 mutations. It's a CR-TAP mutation was the first one found. And then it turned LEPR1 and CR-TAP and PPIB. And what we realized was these 3 genes created 3 proteins that work together in a complex that hydroxylated one very, very important site. They hydroxylated this proline at position 968. It's the only thing they did, these 3 genes. They worked together to hook on an OH group. But if that OH group didn't get hooked on correctly, people had very severe OI. And here you can see 2007, 2009, people are finding these other genes. And every time somebody found a gene, they decided they were going to name it a new type of OI. So we had the original Salentz. We had Dr. Glorio's 5, 6, and 7. And then we started to see all these genes, and the next thing you knew, there were more than 15 types of OI. And the remarkable point of this modified Salentz classification is that all of these new forms were not anymore being defined by clinical type. Remember, we started 200 years ago, and it was all about how many fractures you had and which age did you have them. And we got all the way up to 1979 using this. And now we have type 15 OI, but the last 10 were clinically indistinguishable from the first 5. Molecularly, they were very different. So this type of classification scheme was kind of a portmanteau. It was a mashup between a clinical and molecular classification. This was the controversy. In recent years, some authors have proposed an expanded Selence criteria with each causative gene receiving its own number. However, as the original classification always included recessive forms, the most recent nosology proposed a simplified and clinically friendly approach by decoupling the Selence criteria from the causative gene and only adding type 5 because it was clinically distinguishable. All right, so I'm going to leave the controversy behind, and let's look a little bit about what is OI clinically. When myself, your local physician, when we walk in the room, when we meet a patient, when we meet a baby, maybe prenatally, maybe an adult, what do we see and what are we looking for? Well, you would think that at this point we'd have a really strong fundamental definition of OI, but that's not even true. But my definition is OI is a genetic disorder that causes skeletal fragility, which ranges from in utero death from multiple fractures all the way to an average lifespan with postmenopausal osteoporosis, fractures, and extraskeletal manifestations along the way. I love this panel from the New England Journal of Medicine, Dr. Orwell, and you can see these are skeletons in progressive severity, x-rays of people with OI. This could be my x-ray. But now you start to see some scoliosis, short stature, maybe a little bit of deformity in the femur. You get more severe, you see scoliosis, you see rods. Here you can see very significant deformities and significant differences. And all of these things are OI. So you can imagine that when somebody walks into your room as a physician, you're not going to treat the person on the left like you treat the person on the right. And this is why classification is important, because it doesn't define who you are, but it helps compare you to other folks with OI so we know what we think is the best way to treat these different groups. And again, OI is a clinical diagnosis. It's a continuum based on the propensity to fracture. The classification, it's useful to try and give people prognosis. It's useful to know how it's transmitted, recessive, gonadal mosaic, dominant. It's useful to guide treatment. But knowing the specific genetic change, it's not important. It's not important to start treatment on your child. It's something that we would all love to have. Sometimes insurance doesn't cooperate. They don't want to pay for the test. Okay. Doesn't mean we're not going to treat the baby. It doesn't mean we can't help the family. And I want to get more into this as we go on. It's a very imprecise association. Getting that spelling change doesn't tell me how your child is going to behave. It's not a book for the future. The mutation doesn't write the book. So aside from the fragility and perhaps short stature, we can see dentinogenesis imperfecta, loose joints, loose sclera. Maybe in adulthood, there can be an increased incidence of glaucoma. We can see hernias, easy bruising, hearing loss, cardiovascular changes in adults. And to give you some idea about the spectrum, here you can see a skull of a child who really has no mineralization at all. The skull is not mineralized. Here you can see the skull starts to become mineralized. You start to see some of these Wormian bones. And Wormian bones are these islands of bones. They're not called Wormian bones because they look like worms. They were actually named by a Dutch anatomist named Dr. Wormius. Here you can see varying chest x-rays with different types of involvement. These bones look a little bit thin, these ribs, but in here you can see the ribs are deformed. There's fractures. This is a very small chest wall with almost too many fractures to count. Spines, relatively normal vertebral bodies, and you can see how they become to be crushed. So, this is where when you look at somebody, you would say, well, obviously this form of OI is more severe than this form of OI, is more severe than this form of OI. And we probably see a child like this, and we see these crush fractures in the spine, and we think, oh, we need to be aggressive about treating this child. We want to try and really help the spine. And we look at this spine and we say, that spine looks pretty good. These children probably need different kinds of help. And that's the idea of the classification. That's one of the utilities of the classification. Here you can see long bones, a relatively normal femur, a femur with a small bow. And as the bone gets more severely involved, you see it looks thinner, it looks more crumpled until you get to this concertina. It looks like an accordion. People call it an accordion femur. And this is tibia. Again, fairly typical. You see a healing fracture down here, very thin bones with some deformity, and then the classic sort of archer bow femur where there's bowing from front to back in the tibia. I said femur, I meant tibia, sorry. All right, so how about let's synthesize this again, knowing what we know now. We have all the genes. We have a better, clear understanding about what we see in the clinic. And here I give you Dr. Salentz again in 2014. So what is that? 35 years later, he revisited his classification scheme. And I'm going to do it this way. What do you see on the ultrasounds? Well, type 1, so the mild form of OI, you usually see none, or rarely you see a long bone fracture or bowing. Most of the time, an infant with type 1 OI at a 20-week ultrasound looks like there is no OI. In type 4, in moderate OI, you can start to see fractures a little bit more commonly, bowing, and these changes tend to increase as the baby gets closer and closer to delivery. Type 3 OI, the bones are usually measuring short. Fractures can be seen. Changes in the rib cage can be seen. Changes in the degree of skeletal mineralization. And essentially, the difference between type 2 and type 3 can be difficult to make at a 20-week ultrasound. But the more fractures and the more deformity, the more likely it is to be more severe. When we think about people that have type 1 OI, at least in the pediatric age range, we think about them having about 1 fracture a year. Pretty much an absence of significant bone pain. These are children that are going to school with good attendance. As we start to get into more moderate forms of OI, we're talking about fracture rates probably around 3, between 1 and 3. And these children are beginning to miss some school for fatigue, for pain. Whereas type 3, our fractures are more than 3 a year. Chronic bone pain can be present unless we're treating with bisphosphonates. I don't want to get into medical management here really at all. I think there should be a great pediatric session this afternoon. If you're interested more in treatment, it really is beyond the scope of what I want to cover. It deserves its own hour and a half. And there's definitely more involvement in these children trying to go about what would be a typical school day. And what Dr. Solentz proposed was that we should go back to the original classification. Type 1 is OI is mild, it's non-deforming, it can be caused by mutations in the alpha 1 or alpha 2 chain. The type 2 OI is typically perinatal lethal. It can be inherited dominantly in theory, because if you have type OI, you clearly can't have children. But it's passed on in that way. This is where gonadal mosaicism can come in through alpha 1 and alpha 2 chains. But also, these recessive forms can cause the identical perinatal lethal phenotype. Here you can see now all the genes that could be associated with type 3 OI, with type 4 OI, different inheritance patterns, and then the one single gene now that we know that's associated with type 5 OI. So this is where we live today. You have a brand new child who perhaps doesn't have a collagen 1 mutation. Let's say they have a LEPR1 mutation. And you might go into a genetics office and they say, you have type 8 OI. Or you might come into my office and I would say, the child has type 4 OI that's caused by LEPR1 mutations. Both physicians are saying the exact same thing. And I find this a lot when people come to our center for second opinions, that there's a lot of confusion about this area and what does somebody actually have. And I think this is an important piece of sort of navigating this new diagnosis, is understanding molecularly what's going on and what does it mean to have type 4 versus type 8. It depends on what classification scheme you're in. Are we talking about a molecular classification? Because type 8 OI doesn't tell me anything about your child. It tells me the mutation. Type 4 OI tells me this is a child who has moderate OI. And I know what to do with somebody who has moderate OI. And it tells me, oh, they have mutations in this gene. Great, I need to talk to the family about recessive inheritance. Maybe there will come a day where treatments are customized and unique to an individual's given mutation. But that day is not now. So the last little section is about genetic testing. How do you do genetic testing? Well, first thing you need is some DNA. How can you get the DNA? Well, you can get it from blood, you can get it from saliva, you can get it from skin fibroblasts, you can get it from amniocytes, you can get it from a lot of different sources, but the process is the same. You collect it, you extract it, you amplify it, and then you put it in this machine with some reagents that's called a sequencer. And the sequencer gives you back this string of ATCG that needs to be interpreted. Now, I'm going to show you a couple examples of lab reports and interpretations Without mentioning the labs, I'm going to tell you that everybody can get the mutations if they're there. The interpretation that comes in the report is quality is dependent upon the lab that you sent it to. And sometimes that means, as you see here, the result section can be very difficult to interpret, even for genetics professionals. But here you can see, look, this person has a collagen 1 alpha 2 mutation. It's in exon 29 and it's heterozygous. It means there's one copy of the change. What is the change? Well, remember we talked about the C dot numbers and the address? Here's the address. It's at position 1711. What happened? A G got changed to an A. What did that do to the protein? It changed a glycine to an arginine. Remember that glycine was the one important amino acid that everything curled upon. This sort of confirms osteogenesis imperfecta. And now if you look at the report, it says what I just said in words. And then what it should do is it should reference whether or not this mutation has been described before. This change has been previously reported. Oh, okay. It's consistent with a disease-causing variant. Does this tell us anything about how severe this child is? Nope. It just confirms that they have a diagnosis. And this is a question that comes up. I'm unique. Well, here we have another company's report. Collagen 1 alpha 2. Single change. Here's the address. C.839. A G got turned to an A. A glycine variant got changed to an aspartic acid. Same premise. This triple repeat cannot bend on itself. It's consistent with the diagnosis of OI. Now look, this change has not previously been published before. Does it mean the patient doesn't have OI? No. It means that this mutation isn't in the database. Maybe this is the first individual that has it. Again, does this tell us what kind of OI the patient has? I would say no. It's a clinical classification. You need to look at your patient to know what kind of OI they have. And this is a great database if you have your address and you want to look things up. This is a database that's kept at Leicester in the UK. And here you can see that there are 1,065 mutations that have been reported in COL1A1, 612 in COL1A2. But we know, here's the total number of people, right? It's about 3,000 people here. We know there's way more than 3,000 people with OI. So to say that you have your own version of OI or the mutation is unique to you, to be honest, most people have unique mutations. It's actually a little bit more rare, I would say, to find people that have recurrent mutations than those that have the same. And that's really why we start to think about these things as clinically classifiable. And we group people based on their x-rays and their exams. So with that, I show you some ligamentous laxity and say, thank you. I would throw out there, Navigating a New Diagnosis. This is without being too self-serving, this is a great book. Part of our group helped to put this together. The BBDC has a registry that you could sign up for and get involved with some research, as well as an online new survey that just came up, this Impact OI survey, that your voice would be appreciated. And lastly, I say thank you to everyone on our team and the OI Foundation again for being able to speak.
Dr. Bober, thank you so much. This was a fantastic presentation, so thorough and very appreciated. I want to transition now. First of all, some of my colleagues have put in the link to the new diagnosis toolkit into the chat. So if you want to check that out, please look there. Also, we have received a few, so now we have roughly 15 minutes for audience questions. So we have received ahead of time some audience questions, and some have been sending us questions in as well into the chat. So if you have any questions, feel free to write them into the chat, into the everyone link, or to me specifically if you would prefer to do that. Dr. Bober, I'm going to just jump into some. I know you've touched upon some of these topics beforehand, but I really want to make sure we bring the point home. One is about a little bit more straightforward. What are some of the costs involved with getting genetic testing, particularly if you're an adult who's been diagnosed later in life?
So, yeah, thanks. It's a great question. I think we probably have given our interpretation services today a very wide audience, and the answer here is definitely going to be medical system dependent. Mm-hmm. But at least in the US, it's fairly, I think it's going to turn out to be essentially a couple $1,000s. And whether or not the insurance will pay for it is going to be up to your insurance. I think in my world, we have a group of people that petition the insurance companies to pay for it. We try and get that set up and established prior to just sending it out. There are a couple of genetic testing companies now where if the family has either primary or secondary Medicaid, they will cover testing at no cost. So it would be important to work with your genetic team. But if you were just completely paying out of pocket, I would think it would probably be around $2,000.
Got it. Okay, thank you. And obviously, it's a very U.S. dependent question.
Yeah.
So we got a question in the chat, which is, and I'm for sure going to be pronouncing some of these words wrong, so correct me if I am off. So someone was asking, what about Austen hydropaxipatite? I've read some research that says it's significantly effective in the prevention of bone loss more than calcium carbonate. Is this true? And is it really helpful for OI for adults?
Did you say hydroxyapatite? Is that what you're trying to say?
I said it's Austen hydroxyapatite. I'm going to put that word into the chat for everyone so that we can, so you can see it too. Because I am definitely saying this wrong.
Austen hydroxyapatite. Okay, hydroxyapatite is the type of crystal that bone mineral forms into. So you swallow calcium, you swallow phosphate, and these minerals are put together in a crystalline form that's termed hydroxyapatite, and this hydroxyapatite sits between each of these collagen braids. And in that way, bone is a composite material. It's composed of cells, it's composed of proteins, and it's composed of this bone mineral. I can only imagine if the question is, are you asking if I swallow hydroxyapatite, is it as a supplement, is it better than swallowing calcium? And I think the answer to that question is going to be no, because you can't swallow hydroxyapatite and sort of place it into your bone. You're going to have to swallow something. It's going to have to be digested. It's going to have to be absorbed. And then it's going to have to be created again in the bone. So if that's what the question is, I think the answer is kind of go back to drinking milk.
Gotcha. Thank you so much. We have another question that came into the chat. And so we translated it real quick. I believe it's asking, how are stem cell treatments going in OI research? Is there any news there?
I would defer that. Perhaps the short answer from my perspective is I know people are working on it. I don't think there's any sort of stem cell work that's really ready to be sort of, let's say, a shovel-ready project or a shovel-ready clinical trial, but there are people that are working on that technology.
Got it. Thank you. We have another question here coming in from a parent. They are asking, what is the advice for parents who are still unsure about what type of OI their kid has? This person is saying, my daughter has brittle bone condition, but because they live in Gambia in West Africa, we don't have the required medical services here to confirm her OI type.
This good question. Again, I would, if she's asking for a type by sequencing, I'm not sure that it's super important. If she's asking for a type by clinical grounds, I would almost say if she educated herself with a little bit of the web and she knew what perhaps an X-ray looked like, she could probably make a strong guess for herself. I didn't really get into it at all, but I did mention the LEPR1 mutations. LEPR1 is a gene that does that hydroxyprolination step and is a recessive form of OI that there's a founder effect. In other words, there's a common gene, and it's actually very prevalent in West Africa. And I don't know, but it could be that her daughter, because of just based on geography, that it could be that's what the child has. I think, yeah, if she's getting treatment, I don't know that it's that important to confirm the OI. I don't know if I see Dr. Gloria. I don't know if he has a comment about that. I'd love to hear his opinion, but I would think that you just go on about your business without the mutation.
Gotcha. Thank you. And Dr. Gloria, if you want to unmute yourself, feel free to. Another question we're seeing is...
I'm sorry,
Dr. Gloria,
I missed your question. Yeah, I have some technical problems like as usual. So I missed, Michael, I missed your question.
Oh, just how important do you think it is that somebody has a mutation versus just being able to be treated without it?
Dr. Gloria, I apologize. Your audio is breaking up, but we will try to circle back to this question later. We have other questions here. One is asking, have you seen MBAS mutation related to OI?
Me personally, no. I'm not sure what MBAS is. Is that a gene name?
I am not sure.
So I'm looking at this one question here about my brother has OI, looks like my grandfather and mother don't know the type. Again, the type is clinical, in my opinion. So if you have a care provider who's providing care for OI, you don't need the molecular test to tell you what kind of OI the person has. You need a physical exam and you need an x-ray, and that can tell you the type. If you'd like to know the molecular cause, that's up to you. It shouldn't change anything. It would obviously confirm that you have OI. It would confirm the inheritance pattern, but in this family, you know, there's 3 generations. It's dominant. So, you know, that's the, maybe I didn't make that point super clear, but in my mind, the types are clinical, and you know that you learn the inheritance pattern, and you can learn the molecular basis from a genetic testing, but the genetic testing doesn't determine the type. We see changes all through all the different addresses in collagen 1 or collagen 2. And it can be almost impossible to look at that genetic report and say, this patient is going to have type 3 severe progressively deforming OI, or this patient is going to have a moderate form of OI with some degree of deformity. The genetic testing will not tell you that. Mm-hmm. Only looking at your patient will tell you that.
Great, thank you. So actually, we have 1 minute left, and actually, now the OI Foundation wants to ask a question of everyone here. So as you know, we are using language interpretation for the first time virtually. So I'm going to launch this poll here. We just like people to let us know, are you using English, Spanish, or French for this session today? We would love to know to help better build our future programs. And we will be asking this at every other session with interpretation as well. And with that being said as well, Dr. Bober, I want to just thank you again for this really excellent, super thorough session. We are very thankful to have you with us. Also, I want to let everyone know that if you have further questions for the OI Foundation, please, you can email us at bonelink@oif.org, and we will do our best to get back to you very soon. These medical professionals are really fantastic, and we're so thankful to have their help, and we try to share out the best medically verified information possible. With that being said, I want to make sure that we end on time, because the next upcoming session is the welcome and research update, which will be happening in roughly 15 minutes, and we hope to see everyone there. Dr. Bober, thank you so much.
Thank you all. Have a great day.
Thank you, everyone, and we will see you soon.